Pleasantly surprised. He's the Vice Dean of Physical Therapy at the university and Director of iPhysio Research Group. He's also an editorial committee member of a new journal called the Journal of Invasive Techniques in Physical Therapy. So, no more words, it's up to you. There you go. Thank you very much.
Okay, so first of all, thanks very much for the invitation, Jan, to have the opportunity to be here sharing this time with all of you. So I would like to introduce this presentation about a new way of treating spasticity that I think that all of us as specialists in brain healing can insert in our regular treatments. So for me, this is only the starting title, because when I started to research about all of these things, and I got the first publication with Orlando Mayoral in 2007, I was just thinking in a very narrow scope, which was just trying to reduce hypertonicity or trying to treat spasticity. But at that time, I didn't have a lot of experience. It was my first attempt. And now, as time goes on, I have experience in some other things. So mainly I will be focusing on treating dysfunction. So what I usually say is that spasticity or hypertonicity is a tricky word for me, because it has some difficulties to measure, to know what it is, and really what is important for me is the function of the patient. So we are going to speak about trigger points regarding any kind of dysfunction, as we know that trigger points can be giving a lot of dysfunctions. We have been doing some publications. The problem is that all of them are in Spanish, but now there was a recent invitation in this new book, and I had the opportunity, thanks to Dr. Valera and Dr. Minayat, who published this book, to insert a chapter with a very thorough explanation, because sometimes in the papers you can explain a lot of things, you have to demonstrate everything, you have to say it has scientific evidence. So it was a good opportunity to compile all the Spanish things and put it in English, so the rest of the world can realize that it exists. So as we joke in Spain, if you do things, it doesn't exist until it's in English. So now we are on the way to be existing. So regarding the presentation, sometimes the first approach is how we can manage tone through brain healing. So the first tricky thing for me is what is tone, because people speak about tone, but as my PhD director told me in Kiel, Professor Anand Pandyan, he's a very relevant researcher, and he told me, okay, we have a problem, because if we want to measure tone, we don't know how to measure properly, and especially when we move to the clinical measurement. So we have some definitions, but I think, in my opinion, they are really vague. So if we think how can we measure, there are a lot of measuring devices like myotone, like tensiomyography. They are measuring the passive properties of the tissue, they are measuring the active properties of the muscle when contracting, but sometimes they are a bit limited. But when we move to the real life as a clinicians, because for example in my case I work at San Jorge University, but I'm also dedicating about 10 hours a week to treat patients, because I think it's necessary to be in contact, to see new things. So when I move to the patient, sometimes I don't have this expensive equipment, so I have to use clinical scales. So when I go to the literature, I say, okay, I have Ashworth scale. This is a scale for hypertonicity. It doesn't consider the speed of the movement at all. Or we have the Tardy scale, but as I was commenting previously, for me the most important thing is not just measure this, that is a secondary variable for me, and we should focus in the function. So if we consider hypertonia, there are some studies reviewing these issues, and they say that hypertonia can be the result of different components. We can say one component could be tissotropy, there could be some other central or neural component of hypertonia, and there could be another biomechanical or peripheral component. In these components, we can highlight the spasticity as part of the neural central component, or we can have a look to trigger points as part of the biomechanical or peripheral components. Although we know that trigger points will be related to the central nervous system and will be the gate entry to treat some dysfunctions in the central nervous system. Another question that comes to my mind, at least in Spain, I don't know here in the United States it will be similar, is that when I attended classes in my degree of physiotherapy, when I was going to musculoskeletal classes, there were only muscles, joints, some specific tests, but patients didn't look to have a central nervous system sometimes. And when I attended my neuro classes, patients were so global that they didn't look to have muscles. So this is also a bit concerning for me, because I understand this is a complex reality and our minds need to split the reality to study, to understand, but we should treat the patient as a whole. So my reflection here is that even if we have a neuro patient and if they are receiving injections of botulinum toxin, it's not something strange that we can use dry needling to treat trigger points as a source of a cause of dysfunction. So, how can we intervene with dry needling in the patients? We have different hypotheses. When we started, we were thinking about some peripheral components. So we thought about the trigger point, so like an entity which has some kind of abnormal electrical activity, so it may be causing some kind of resistance to passive movement. So more or less this was our first idea. So we considered the trigger point as partly responsible of this hypertonia in neuro patients. But in this first study, we realized, surprisingly, that we found just the other hypothesis, just the opposite one. We found that component related with the speed was changing much more. So my question was, okay, I was treating a trigger point to reduce this peripheral activity, and I have found that the central activity is changing the most. So what's happening there? In that moment, we couldn't think about a lot of things, so we hypothesized that perhaps the local twitch responses were some reflexes that were having some links with the myotatic reflex response. So some way, perhaps they can be modulating this myotatic reflex. So it was just an hypothesis, but as time goes on, I think that provoking local twitch responses are the best way to modulate this and to get significant results when treating patients. So my conception of trigger points is that they cause any kind of dysfunctions. We know they give pain, they cause motor alterations, vegetative alterations, proprioceptive information changes. So my point is that a trigger point could have the ability to change things in the central nervous systems regarding the function of neuro patients. So this is the rationale, so I'm working to treat them. So I have some questions for you just to think about them. So you know a lot of things about trigger points, and you know that reciprocal inhibition can be altered or absent when the muscle that is activated contains trigger point. So this can be a cause for the contraction of muscles, but perhaps when we go to musculoskeletal patients, this is nothing very easy to see. Perhaps we can do some EMG, we can record it, but this is not obvious when we are just evaluating a patient. But one of the things that this treating of neuro patients has shown me is that some things that are not very evident in musculoskeletal patients becomes very evident when we treat neuro patients, because they have a very big dysfunction regarding the trigger points. So perhaps if we have a loss in the quality of the movement, I'm going to ask you a question is, can trigger points be partially at least responsible for the muscle overactivity in patients with central nervous system? Does it make sense? So we can treat trigger points to try to reduce this overactivity, to try to improve this coordination between agonist and antagonist. Another question is that we know that these trigger points are responsible in the literature of a lot of recruitment disorders, and there are a lot of studies explaining that latent trigger points, even if they don't give pain, they are responsible of some recruiting disorders. So for us it's important even if they are latent. So my question about that is if trigger points can be partially responsible for the lack of coordination of some movements in neuro patients. Does it make sense also, this? So perhaps we can treat trigger points to try to get some changes in the patient coordination patterns. So which is my working hypothesis? My working hypothesis is that I'm going to treat dysfunction. So I have evolved from this very simple term of spasticity, hypertonia. So now I'm going to focus on treating dysfunction, as I consider the trigger points are a big source of dysfunction for this patient. So when I started, I was having a very narrow scope saying, oh, this muscle, this trigger point is overreacting, I have to decrease the activity. I'm trying to do this kind of mechanical disruption of end plates and all these issues. But as I have been working, the concept is not reducing overactivity, the concept is normalizing function. So if I have a very reactive muscle, I try to treat it to get more functional and not so reactive. But when I have a weak muscle, we know that a weak muscle may contain trigger points. So if I treat a trigger point in a weak muscle, it's possible that I restore the function, so I get overactivation of this muscle which is temporarily weak. So more or less the point is getting to the normal state of the muscle.